So, thank you all so much for joining this great session on COVID-19 vaccine rollout, its challenges, and the prospects. I am Charles Shea Wisonge. I work for the South African Medical Research Council. And this is, I'm sure you will find out that this is one of the greatest sessions you will attend, of course, in addition to all the other ones around vaccination. And we have a great panel to talk about vaccination today. As most of you would know, vaccination started with smallpox in the 18th century. And it is also smallpox that holds the record for the first disease to be eradicated from human history. And this happened 41 years ago. And the success of the smallpox eradication initiative led to the concentrated global effort to use vaccination as a public health intervention, which started in 1974. And since then, vaccination has changed our lives. By 2019, vaccination was preventing 5 million deaths, and these were deaths each year. And these were deaths that would have been caused by measles, by whooping cough, by tetanus, by polio, and diphtheria. And this is not including the deaths that would have been caused by smallpox if it had not been eradicated. And we can likely have the same impact for COVID-19. It could also be eradicated if there is optimal uptake of currently available tools, including amongst them vaccination. But we all know that currently there are about 4.7 billion doses that have been administered globally as of yesterday, and 31% of the world population has received at least one dose of the COVID-19 vaccine, but only 1% of these people who have received are living in low and middle income countries. And in our own country, about 12% of people have received at least, as we'll hear from Dr. Nicholas Cripps, about around 12% of people have received at least one dose of a COVID-19 vaccine, and only about 7% are fully vaccinated. So this is a session where we'll look at what the challenges are and what the future holds. And we are going to talk about COVID-19 trends, vaccines and herd immunity from Professor Hassan Mohammed, about the national vaccine rollout from Dr. Nicholas Cripps, and the public-private partnership with Nolotando, and vaccine manufacturing with Morena. And I'm going to start now with Professor Hassan Mohammed, who works for the provincial government of the Western Cape in the health department, and is also a professor at Stellenbosch University. So over to you, Hassan.
Thanks so much, Charles. I think just confirm for me that you can hear me.
I can hear you very well, Hassan.
Okay, good. Let me go through my presentation. So basically, I'm going to start off with a global situation with COVID. We've had more than 200 million confirmed cases of COVID around the world and 4 million deaths associated with that. It's likely that both of these numbers are an underestimate. So there's no doubt that this is an unprecedented pandemic that the world has experienced. In the South African situation, we have had more than 2 million cases, or 2.6 million cases, about almost 80,000 deaths. And again, so South Africa as a country has been significantly affected by this pandemic. We know about variants, and variants have been an important feature of this pandemic. And we started off with the original variant. We were then dominated for a long time from late last year with the Beta variant. And we have now the Delta variant that has taken over as the dominant strain. And each of these variants bring with it its own challenges and difficulties that we need to deal with. In terms of COVID-19 vaccines, so I think just to remind you, what is a vaccine? It's a biological preparation that provides active acquired immunity to a particular disease. It typically contains an agent that resembles a disease-causing organism and is often made from weakened or killed forms of the microbe or one of its surface proteins. So it in itself cannot cause disease, important to emphasize that, but it's a part of an organism that provokes an immune response. I don't need to repeat what Charles has already said, that vaccines have achieved a huge amount for the world in terms of saving lives. We have at least 10 vaccines that are freely available through the public sector in South Africa, and they are making a huge difference in terms of preventing a whole range of infectious diseases. We know that smallpox was eradicated in 1979, and interestingly enough, Africa was declared polio-free just in the middle of last year on the 25th of August. And this has been a major achievement for the African continent, achieved through vaccination. Well, what about COVID-19 vaccines? So I have a list here of about 9 vaccines that have been shown to be efficacious. And the interesting characteristic about these vaccines is that they seem to be more effective against severe disease. Most of the trials of these vaccines have been published in peer-reviewed journals. Our aims with the COVID-19 vaccine in South Africa have been to protect the health system, to prevent severe illness and death, and to reduce transmission with a view to herd immunity. We've vaccinated health workers, we've vaccinated older age groups to prevent severe illness and death, and Dr. Chris will talk more about that. In terms of herd immunity, the situation is a bit different, and at this moment we are not quite sure whether we are going to be successful with achieving herd immunity. But countries that have had huge rollouts of vaccines like the USA and the UK, they are seeing the benefits of reduced mortality from COVID, even while they still have surges of infections. There have been a number of vaccine effectiveness studies, and what I mean briefly by that is the clinical trial tests what's called efficacy under controlled conditions. But when we test the vaccines out in the real world, we describe what we see as vaccine effectiveness. So beyond the clinical trials, in a whole number of countries, there are clear signs that these vaccines have not just been efficacious in the trials, but also effective when implemented in the real world. And that is a very important message. Was the vaccine development rushed? Definitely not. There have been very good reasons why this vaccine was able to be developed quickly, and we can engage in that further in the discussion if it's needed. Dr. Chris will go into more detail as to which vaccines we are going to be getting. Just coming to the concept and ending off on this whole concept of herd immunity. Herd immunity describes the type of immunity that occurs when vaccination of a portion of the population or the herd provides protection to unvaccinated individuals. In other words, should we reach a certain percentage of people who are vaccinated, it doesn't matter if those last 5 or 10% are not vaccinated, they will be protected due to the interruption of transmission. That's the ideal, and we've achieved that with diseases like smallpox and polio. However, the experience from COVID is a bit different, and we need really very high rates of vaccination and protection in order to achieve herd immunity. And there's a very interesting article published by Professor Mahdi in the South African Medical Journal that explains this in a little bit more detail. So on that note, let me go back and conclude my presentation, and back to you, Professor Charles Waisongi. Thanks so much.
Thank you so much, Hassan. Very great talk there from you that sets the pace for what vaccines are and what the impacts have been and what vaccines are available in South Africa. And in South Africa is the government that leads the vaccination program, whether it is for COVID-19 vaccine rollout or for other vaccines. And here we have Dr. Nicholas Cripps, Deputy Director General in the National Department of Health, who is going to talk to us about the national vaccine rollout. Over to you, Nick. Nick, we cannot hear you. We cannot hear now. Okay. Mary, can you check?
Dr. Nicholas, if I can ask you to just refresh your page, please.
Where Dr. Cripps is refreshing his page, I would encourage you to put up use the comment section for your comments. There are also emojis that you can use, as some of you have been using. Over to you, Nick.
Okay, thanks. Can you hear me now?
Yes, I can hear you.
Excellent. Thanks very much. Okay, thanks very much for having me. So it's very hard in 5 minutes to try and describe a program of this magnitude. So I'll just try and keep it short to some headlines instead of talking about too many figures. So obviously everybody understands that we have to have vaccines in order to do a vaccination program, but there are lots of other components and issues around how to get those vaccines to people and to make sure that we are targeting the right populations. So the vaccination program essentially focuses on 4 major components. The first one is the vaccines. In the beginning, it was very difficult to secure vaccines in a globally competitive market. Months before vaccines were due to be even on the market, we were busy as South Africa looking for vaccines, and securing those vaccines is quite a business, as you will have seen from the media from time to time. So we secured originally Pfizer, Johnson & Johnson, and AstraZeneca. The Johnson & Johnson vaccine, as everyone knows, was used in the Sisonke program as a major replacement when the AstraZeneca vaccine was found to be relatively ineffective against the beta variant, which we had at the time. Since then, Johnson & Johnson went into a tailspin, and most of the global supply had to be destroyed because of some contamination issues in the Baltimore plant in the United States. And we were very dependent in South Africa then on only one vaccine, which is a Pfizer vaccine, a 2-dose mRNA vaccine. So at the moment, we have now restored Johnson & Johnson vaccine as the second vaccine. We ordered 31 million doses altogether. We have ordered or been donated around 40 million doses of the Pfizer vaccine. We have 2 other vaccines that are still in the wings. The one is to return to the AstraZeneca vaccine, which at this stage is effective against the Delta variant. But of course, we are sort of moving towards the end of that this third wave. So we're not sure whether the next wave we will experience will be the same or different variants. And then there's the Sinovac vaccine, which has been registered provisionally under some conditions with SAHPRA, and that still remains an option. There are some conditions that still need to be met before we can procure it, but it would mean that we would have up to 4 vaccines available should we choose to procure the other 2 as well. We have plenty of doses in the country now, but 3 weeks ago we had almost nothing left. We were down to well below 1 million doses spread across all the sites in all the provinces and the private sector. And so parts of the supply chain ran dry, and that has given a loss of impetus to the program. The second part of the vaccination program is the capacity to deliver the vaccines. So that includes having the syringes, the needles, the vaccinators, the transport, everything else that goes together with setting up a site and managing a vaccination site. We now have the capacity, as we sit today, to vaccinate 300,000 doses a day. but we don't have the demand to, and I'll talk about that in a moment. So the capacity, we still do have some spare capacity between the private and the public sector that we can bring into online. But we are, as of today, vaccinating in well over 3,000 different locations around the country. The biggest sites can do over 4,000 vaccinations a day in one place, and the smallest ones do between 10 and 20 vaccinations a day in small community pharmacies and mobile outreaches to farms and small rural communities and so on. So it's a very wide range of capacity for delivering vaccines. The third and the biggest challenge at the moment is demand and demand generation. So you need to have people, and we have a population of around 60 million people, of which 40 million are adults, and that's our target at the moment, is the adults. That's not to say vaccines will not become available to children later, but for now, from 18 and older, that's the target population for which our vaccines are registered. Right now, as you know, we are vaccinating people older than the age of 35. We have reached more than 50% of the people over the age of 60 so far, but over 50s are still lagging a bit behind, only sitting around 35% vaccinated. Overall, in terms of the adult population, we are just over 20% of the adult population vaccinated, and in terms of total population, 12.5% vaccinated. So we have 7.5 million individuals vaccinated, just over 9.5 million doses given, and the difference is that we have 4.2 million people with completed vaccinations. In other words, either a Johnson & Johnson or 2 Pfizer doses. The demand has decreased, and it decreased differently in terms of geography, men and women, and between rural and urban. We've seen much better uptake in rural areas than urban areas, and we saw better uptake in older people than younger people, which is actually a bit surprising. But maybe we were just being too hopeful that there were 12 million people in the age 35 and up. So there are a lot of strategies under development at the moment, some not to do with communication and negating some of the negative press and the very strange things that people seem to believe that are spreading on social media. And then the other is around improving the way in which we are able to physically outreach to communities. I can go into details during questions if needs be. The last component is about analysis, planning, and communication. You will understand that to vaccinate 35 million doses, which is our target by the end of the year, you need to keep a very close tabs on where these vaccines are, who's getting administered what, where, and when, the individual doses, tracking the adverse events that are reported, and making sure that we are able to target where people are being left behind. For that, we have the electronic vaccine data system. It has many components to it, of which the registration and scheduling are a part, but the analysis is the most powerful part, where we can watch almost live what is going on in our control center. We use that data for planning, both vaccines, where the vaccine should go, forecasting when we think that we are going to need additional supplies, and for making decisions about where to put the next capacity and so forth. And then also for targeting our communication. Communication is a challenge, but we have now got a very good working relationship with GCIS, the Government Communication Service, and the private sector from B4SA, who is a partner of ours in both the service delivery platform and in the communication. I think I must leave it there, because otherwise there'll be no questions to ask. Thanks very much, Charles.
Okay, thank you so much, Nick. And that was very useful to hear from you where we are with the national rollout. And there is a comment in the chat that you should open up to the 18 to 35 in order to increase demand. And I know that the government cannot do it alone. We need the communities to be engaged. We need everybody to be to work with the government. And the private sector has come to the party, and we know that it is important to have a public-private partnership for this vaccine rollout to be successful. And there's no, we have Nolutando, who is well placed to tell us about public-private partnership for vaccine rollout. Over to you, Nolutando.
Thank you so much, Charles. It's really a pleasure to be part of this panel. and thank you for the invitation. So I think for me, I'm going to start maybe my talk just, thinking about our commitment to the fight against COVID-19 as the private sector. I think right from the start of the pandemic, we have been committed to playing our part in supporting government's efforts in the fight against COVID-19 with the aim of ultimately reducing mortality and morbidity and to restore social and economic activity and really protect lives and livelihoods. And I think we've done this through education and awareness right at the start of the pandemic, funding for screening and care of COVID-19 and supporting our employer groups, our healthcare workers, our scheme members and the broader South African community, through this process and ensuring that, with the resources that we have in the private sector, we share these by participating in industry forums, providing actuarial support, public health support, and including public relations support. I think COVID vaccinations, when they came, we were already prepared because this is really a continuum in the fight against COVID-19. So when the discussions were taking place around providing access to these vaccinations, for us, we were already prepared to almost partner with the public sector to ensure access to these vaccines. I think when I think about the response in terms of our approach to vaccinations was really around providing education and creating awareness on COVID vaccines, their efficacy and safety. We've done this through various platforms, and we've hosted webinars. We've shared data. I think it's important to highlight some of our recent partnerships with the Sisonke trial team to analyze the Sisonke trial data, where the private sector aspects and the data that we have from a funding point of view was incorporated in the outcomes data that was shared. The other big component, obviously, is about creating access through private sites, including mass vaccination sites, and our big partnership with the Western Cape Department of Health, with the Cape Town ICC. And we've got our own other mass vaccination sites, in the Gauteng region, and we've partnered with the Virgin Active, teams to provide broader access. And I think we are also working very hard in supporting employer vaccination sites to ensure that we bring the vaccines closer to the people, and by so doing, try and improve uptake to vaccinations. The other support, obviously, is around funding for vaccines and their administration through the medical schemes funds, and this was also facilitated, earlier on to ensure that all the private sector, people who are, insured have got access through these, and they are funded accordingly. And I think ongoing participation in key industry platforms is key for us because it allows us to understand where gaps currently exist and to offer, resources where we can. And this is really as part of our ongoing support through resource allocation. To date, at only the Discovery vaccination sites, we have vaccinated around 375,000 lives. And on average, at the peak when, people were really coming for the vaccines, we were doing 20,000 daily, but that has since dropped to around 10,000 across the various sites. So some sites, we're seeing quite low occupancy rates. Right now, the range is between 50 to 75% occupancy rates at our sites. Quite interestingly, we've got 2 sites in KZN where we have seen very poor uptake in terms of vaccinations in that region. But I think it's always nice to compare that, with the uptake in the public health as public sector sites as well, to see if maybe there is better uptake in those areas as well. And I think it's important considering, the size of the province like KZN. I think, like Nick has already alluded to, I think the challenge going forward is going to be around getting people into the vaccination sites. And I think vaccine hesitancy is becoming a real issue. And I think we know some of the drivers. I think with some of the analysis that has been done, there was an interesting paper that was produced by the Solidarity Fund, unpacking some of the reasons why people may not be taking up vaccines. It's really, the next challenge now, considering, some of the other challenges that we've faced in terms of, making sure that we've got adequate supply. Now it is really about getting people to the vaccination sites. And I think, our teams are working very hard to also just look at strategies that we can put together in support of government's initiatives, to also drive some transparent and robust communication to shift what we consider the movable middle. And I think this is very critical, especially when we're thinking about, the next move to the 18 to 35-year-olds, where we do need to be thinking very differently to potentially, when we structure our communication, because these are younger people who may actually require a different way of communication. So what is that going to look like? Because we do need to ensure that we keep the momentum going, we keep people vaccinated, because it's the only way we can actually, get to save lives and also to preserve livelihoods. I think I'll also stop there and allow, maybe the question and answer session to people to ask specific questions that we can answer during the course of the panel discussion.
Thank you so much, Nolutando. And it is important, I think we are grateful that the Discovery and other private sector stakeholders have come to the party, not only in terms of service delivery, but also trying to counter vaccine hesitancy. And we know that one of the barriers, as we've seen, to vaccine uptake in South Africa, we have the vaccine now, but we know before that there were issues of supply and access, and of course, we've mentioned hesitancy. And one way of ensuring that we should be self-sufficient in vaccination, in terms of delivering vaccination services, is to be able to make vaccines ourselves here in South Africa. And we have here Morena, who is the head of the BioVac Institute, which is the one name that when you talk about vaccine manufacturing in South Africa, it should come to the forefront. So I will hand over to Morena to talk to us about vaccine manufacturing and also other aspects of the vaccination service. Over to you, Morena.
Thank you, Charles. Can you hear me?
Yes.
Okay. Thank you very much for the invitation to this forum, and particularly for including the manufacturing aspects as one of the topics. The vaccine manufacturing space on the African continent has been a very lonely place up to the time that COVID hit. I think we were the very few lone voices that were speaking about the need for local vaccine manufacturing. And the majority of the response that we got, and from a wide variety of people, including industry participants, was that, is it worthwhile putting up vaccine manufacturing? BioVac, is it sustainable? Are you mad? What are you doing? Will you be able to compete with India? Is it worthwhile? And so it's been a very lonely place in terms of us advocating for vaccine manufacture. I think in any dark cloud, there is a silver lining in that, as much as the COVID has been a very dark cloud where we've also lost many, many lives globally. I think the silver lining in terms of realizing why we need vaccine manufacturing on the continent is there. And I'm hoping that if we get a much more infectious organism next time, that Africa will be ready. So I'm just going to utilize a few slides, Charles, in terms of just talking about where we are as a continent. If you don't mind just confirming that my slides do reflect.
Yes, I can see them.
Okay,
Morena.
Thank you.
Yeah.
Thank you.
Mm-hmm.
I have busy slides, but I think it's just to ignore the busyness. I think what I'd like to just show you is that in the vaccine community, the global vaccine community prior to COVID, there has been these 10-year goals that have been put together by multilateral organizations, WHO, UNICEF, and others. And I just extracted this one that was putting together diseases and when the world will think diseases will be in there and what needs to happen in the next 10 years. And you will see where the arrow is on the top right is that local vaccine manufacturing in Africa was targeted to be, if you go down somewhere around 2030. And this was this was prior to COVID. So this is how the world was looking at when will fully fledged vaccine manufacturing happen on the continent. So you could see that, for those that were advocates, they even had quite much longer time frames than we needed. And unfortunately, we are paying the price. We know of the export bans out of India. We know of the hoarding of vaccines elsewhere. But I just wanted to put where the vaccine community was placing vaccine manufacture. And so prior to what's happening now, and the dots that you're seeing now are not necessarily illustrative of the number of vaccine manufacturers, but I think it's just to show you how limited vaccine manufacturing is on the African continent. Asia, particularly in the developing world, India, Indonesia, Vietnam, China, and others have some vaccine manufacturing capability. Latin America also has, but as you can see with our continent, which is in excess of 1.2 billion people, there's very scarce vaccine manufacturing happening. And we know that, we then have those that are in the developed world, including multinationals. So where was Africa getting the routine vaccines from? This is prior to the momentum that COVID came in. And by this, I'm excluding South Africa because South Africa was in a somewhat unique space. But I just want to talk from a continental perspective in terms of how the world has actually been happening behind the scenes. So with the slide, what I'm showing is just to show the contrast between the blue on the left and the blue on the right. And this is prior to COVID, where the countries that are, the manufacturing locations that are on the left, the blue, you can see contrast very much with where the vaccine volumes were going to. So when you look at the African continent, a large part of our continent was dependent on donors to provide vaccines, and those donors would then get vaccine from manufacturers that are on the left. So the difference in shades, on your right, is that there are some countries that are more dependent on donors than others. So if you take South Africa as an example, why it's shaded in grays because it buys vaccines out of its own fiscus. Whereas other countries that are more, the darker it is, the more dependent they are on donors. And I'm talking about routine vaccines now, not even talking about COVID vaccines. And so this is how the continent has been dependent on others, on donors firstly, in terms of making funding available. But those donors have been buying vaccines from the countries that are on the left, mainly being the US and India and everywhere else. And I'm emphasizing routine vaccines because once the pandemic goes, we need to make sure that we still have a viable industry. And a viable industry cannot only come up when there's a pandemic, it needs to be there during routine vaccine manufacture. I'm also going to go through a very busy slide, but this is just really for illustration purposes. So a lot of the names that people would have heard about that, like Pfizer, J&J, and others, is what, let's call them traditional vaccines. And this is just a slide that is really something that I tried to put together because I couldn't find any other data that would represent the message that I wanted to. But as you can see that, there's what we call traditional vaccine companies. These are companies that are in their day-to-day, pandemic or not, are involved in vaccine development and vaccine manufacture, okay? And when you look at Africa, we have ourselves as BioVac, which I'm representing. We have a company in Senegal called Institut Pasteur Dakar, and we have Vaxera as an example. So you have those traditional vaccine companies. You then have, what I term, and this is just, the biotech companies that were there, but that were somewhat enhanced by the, by the likes of the pandemic. And, people would recognize names like Moderna, like Novavax, like BioNTech, which has partnered with Pfizer. A lot of these names were not known because they were small biotech companies, and they've now come to the fore when it comes to COVID vaccine manufacture. It doesn't mean that they were set up for COVID vaccine manufacture. They just had technology that they just applied in response to the pandemic. And then this column is that where you have a traditional pharma company that has some sterile capability, but their main business is a pharma business. It's not a vaccine business, that have manufacturing vaccines or COVID vaccine because they have the sterile capability, mostly within the fill finish perspective. And this list, as I say, I mean, it's just my simple compilation. The missing parts are probably need to be, but you can see that a lot of continents, including in our own, the likes of Aspen Pharmacare, have also stepped in terms of that. But when you look at those companies, their main line of business is being pure pharma. And then we have what we call pure contract manufacturers, the guys that are really, their business is to serve others and not to do R&D, but just to really as contract manufacturer. You may have heard of this name called Emergent, and I think Dr. Nicholas Crisp spoke about it, where there was a bit of an issue where J&J had contract manufacturing Emergent. You can see them there, and that's what these guys do. And then lastly, we have academic institutions that in other parts of the world are doing some development work. They don't do manufacture, but they do development work. The likes of Oxford University that I'm sure people know about, that have partnered with AstraZeneca, and we have others there. So I just wanted, just maybe with these few words, Charles, maybe just my last slide. My last slide is really just to say, what does it take to be a fully fledged manufacturer? And I'm hoping through this, it shows that the challenges that need to be there. Doesn't mean that we should be complacent and just end at just doing COVID vaccine manufacture or doing some full finish. Really, this is what it takes. You need to have product development capability. You need to have some capacity for early clinical development work, and before you scale up, which is the third column, which is scaling up. So a lot of what you'll see from what I call a traditional vaccine company is that you would have all three of this within your institution. People would mostly see what's happening on the third element, which is, we now have a Pfizer vaccine, or we now have a Moderna vaccine. But in actual fact, a lot of what's happening behind the scenes is in 1 and 2. That's quite expensive. It's risky, and it requires deep pockets, patience. It requires also a different set of skills. The skills that you have in 1 and 2 are different from the skills that you have in 3. With us as as BioVac, this is what we've been doing. Even though we have in small pockets, but I mean we do have limited capability in 1, 2, and 3. So we do try and plug the gap. But as I said, that beyond COVID, we do need the support as an industry in general to make sure that there's sustainability on the continent, so that we don't find ourselves here where we are. We get told about export bans. We get told about others hoarding vaccines. And some of the contractual obligations that we find ourselves in as a continent. However, we do need private sector support. We need government support. We need NGOs. We just need about the whole world to understand what it actually takes to be a fully fledged manufacturer. But I'll pause here, Charles, and then maybe then we can then go through the chat and take it from there.
Thank you so much, Morena, for making vaccine manufacturing look so easy from your presentation. Thank you for explaining all of that very well. And there's a lot of interaction on both the chat and the question and answer session. And I will bring some questions on manufacturing to you later on. So there are various questions. Let me just take the one about the duration of protection. And Hassan, maybe I would like you to give this to you. For how long does the vaccine provide protection against severe illness? Maybe you can answer that and also talk about duration of protection from these vaccines. Over to you.
Yeah, no, thanks so much. And I think we all need to understand that, these vaccines are all relatively new. They are still being evaluated on an ongoing basis. So we don't have certainty. And I think, as I tried to explain in the chat, we've got data now to see that these vaccines, the vaccine protection lasts at least 6 to 9 months, because And just remember, these vaccines only became available and started being rolled out about 9 months ago. So all our data is relatively recent. It is likely that the protection lasts longer, but we need to keep monitoring. This relates to the question of whether we might need boosters at some point in time. But again, as the World Health Organization has said, and we must listen to them, let's first vaccinate those who have not received any vaccine before we start providing boosters to those who've already received a vaccine. The Sisonke published data recently from their trial on Johnson & Johnson, and they made a very clear statement. No boosters required at this point in time because the duration of protection is between 6 to 9 months, and it is robust. Nevertheless, this is a situation or an issue that needs constant monitoring, and there is ongoing follow-up in many of the clinical trials, even those that have published results in the meantime, and it's a matter of wait and see, and for us to be patient, and eventually we will have answers to these very important questions. So thank you for those questions. They are important questions, but as I've indicated, we don't have all the answers. Important for all of us who are involved in this field to acknowledge that we do have many answers now, but we don't have all the answers, and further research is needed, ongoing monitoring, ongoing evaluation of implementation is needed, but important for us to follow and monitor those results and to respond accordingly. Thanks so much.
Thank you so much, Hassan. Yeah, and there have been various other questions. I see some of them Nick has responded to, and there is Nick, I would just ask this one about vaccine mandates, and then you can also, after that, you could also look at the other questions which you have responded today and just talk a bit more on that. So there's one question about what are your views on vaccine mandates?
So I'm not sure what the question means about vaccine mandates. Might mean different things to different people.
Yeah, maybe let me assume that they're asking if there will be mandatory vaccination in South Africa and what are your views about having mandatory vaccination. But if this is not what you meant, Adele, maybe you can just write again there, but over to you, Nick. Mm-hmm.
Okay, thanks very much. So at this stage, we have just got so far to go before we vaccinate enough people that we haven't even really entered into the debate about whether it should be mandatory or not mandatory. And together with that, about how to deal with incentives. We have looked across the world to see which countries have made vaccination mandatory or are talking about making it mandatory. We have also looked at vaccination cards, whether people make certification mandatory or not, and vaccination passports and so on. And the bottom line is that these are fraught. They open us for a lot of fraud. We've already started seeing fraud in South Africa where people are selling cards. We've had information from other countries where whole shipping containers have been received from other countries of people sending completed vaccination cards to sell. So the minute you start to force people to do things as a government, you create a whole new lot of problems for yourself. But I suspect that what's going to happen is much like the smoking legislation started. What will probably happen is that people in certain workplaces are going to say, I'm not prepared to work with somebody else who either doesn't wear a mask or isn't vaccinated or is too close to me, etc. So we as society are going to determine this rather than making a specific government statements from the top. Obviously, in government and from the position that I sit in running the vaccination program, we believe everybody should get vaccinated. We wouldn't be pressing a vaccination program and working so hard at it if we didn't think it was valuable. We think the evidence is very clear that healthcare workers who were vaccinated early on in the Sisonke trial are not getting sick. And where they do, it's very mild. And we haven't seen a death from a healthcare worker in the Western Cape in hospitals according to Professor Mark Mendelson, since the beginning of the national rollout. Those are remarkable absolutely remarkable if you think how many other people have got really sick and died. And many health workers are in vulnerable age groups and have conditions that may make them even more vulnerable. So it's a double-edged sword. Forcing anybody to do anything is always a double-edged sword. But there's nothing to say that at some point in the future it will not become mandatory. One would just tread cautiously on making that kind of statement. Thank you.
Thank you so much, Nick. There have been various questions around vaccine hesitancy, and I saw some answers from Professor Rose Burnett, and I think we'll bring her on at some point to just talk on the issue of vaccine hesitancy. But questions also have been asked also about, we know hesitancy, various segments of the population are hesitant for various reasons, and some of them include healthcare workers. And maybe I would like to come to you, Nolutando. Can you talk to us about how at Discovery you've been able to, what have you done in terms of vaccine hesitancy among healthcare workers, and any experiences you can share with the audience?
Thanks, Prof. I think we really have not even scratched the surface in terms of addressing vaccine hesitancy. Like I said, this is something that we are still working very hard to actually crack. I think from our side, education and empowering our healthcare providers with the relevant information around the safety of vaccines. And I mean, data sharing, showing what the studies are showing. I think the Sisonke trial data was very powerful, because before it was released, we saw a lot of reluctance and in fact, maybe not reluctance, anxiety around among some of our healthcare professionals. When we have hosted some webinars, people worried that they are not fully protected with the single dose J&J vaccine, wanting to boost with the Pfizer vaccine. So I think the data that came out was really reassuring, showing very strong effectiveness and protection against severe illness and death. So I think for us, it's really about ensuring this transparent communication. And I think the importance around healthcare workers is that they are not only, important. The information that we're sharing is not only important for themselves, but it is also for the patients that they look after, because data shows that those people, I mean, a lot of people rely on their doctors in terms of the information that they trust. So if we can get our healthcare workers sharing, this important data with their patients and, encouraging them to vaccinate, we would have won half the battle. But it does appear, I mean, we've seen in the recent days some prominent clinicians coming out with anti-vaxxer type of messaging, which does not really help much in terms of promoting vaccinations in the broader population. So I think, like I'm saying, we have been doing some work, but there's still more that needs to be done. And, it's really understanding, we work with data, and data informs, how we then respond in terms of addressing some of these issues. But definitely our teams have got a very focused strategy around how we address hesitancy, and various platforms that we can use, and targeting specifically clinicians as well in that process.
Thank you so much, Noritando. And I think the issue, we all have to be vaccine ambassadors. We all need to be advocates, share the positive stories of our vaccination. For example, I had the Johnson & Johnson as a healthcare worker. Other people do have side effects. I didn't feel any.
Oh dear, we've lost our chair.
I think
maybe we can continue ourselves until he finds his way back to us, so that we don't waste time.
Yes.
So yeah, so I was, if you don't mind, I would like to chip in and just say that I think that everybody hears a message differently. But what is clear to me, listening to the very many, and I get probably 20 to 50 emails a day from people who are complaining about one thing or other with the vaccination program. And I don't sit on social media, because I'm one of those old people who listens to the radio And that's where I get my messages. And it's clear that many older people do get their messages from the radio, and many younger people get it from social media. And what rural people listen to and what urban people listen to are quite different, and which local radio stations people use. So we need to be far more flexible. We need to be able to get to every single kind of communication, and we need to be unequivocal in our messaging. And we need to package it in words that are not health professional words, that are very, very clear for the public to understand. And we must not deny when there are problems. I had my second Pfizer vaccination yesterday. Now, I've deliberately tried to follow my own rollout scheme. The first vaccination, I had to wait some time. When I got to the queue, it was a bit of a shambles, and I discovered that it was because of the billing of my medical aid that held things up. There was nothing wrong with the vaccination program or system. The second time, I missed my appointment because of a meeting. I missed 2 further attempts because of long queues. Yesterday, I finally got my second Pfizer vaccination because they saw my gray hair and ushered me to the front of the queue. And I must tell you, I didn't feel good last night. And even today, I battled through the day today with the muscle pains and the headache and so forth. There are side effects. But tomorrow I know I'll be fine, because that's what happened in my first vaccination. And now I know I'm protected. We need to be real people speaking real language to people who are concerned. And we mustn't label people badly just because they don't believe what we believe. Thank you.
Can I add to that, Nicholas? Because I think I share the same sentiments. And I think, which is why I refer to the movable middle, which is, it's not people who are anti-vaxxers. And I think the labeling is what also, just creates more issues. But I think people are really just looking for transparent information. I'll give an example of a case. I actually got an email from this particular lady. When she first interacted, she was very, aggressive and saying, you guys are not giving me the information. I'm worried about infertility and vaccines and stuff like that. And I shared detailed publications around, her concerns. This morning, she sent me a message saying, I have decided to vaccinate. And she was very grateful of the conversation that I had with her. And I think the way I positioned it also was that there must be an understanding that when we talk about side effects, we also look, there's a public health view to side effects. So if we say it's 1 in a million, you could be that one person. So when people make decisions around healthcare, it is really at individual level. And I think we've seen, even with vaccinations, most of the people, from the data and from the research, they are not vaccinating to save the broader public. It's really at for their own individual benefit. And therefore, even when they consider the safety of the vaccines, they are looking at their own selves. So I think when we provide information, it must be transparent, it must be authentic, it must be real. Where we don't know, when we don't have answers, we say we do not have answers. Like Prof. Hassan just said, there isn't much else that we can say beyond this point, because this is what we have in terms of the available data. And I think that's really what we need to do, and also simplify the messaging so that people understand what they're hearing, because obviously we're competing with very loud voices on social media. So it's very important to also have very simplified messaging that really reach people, and also not dismiss the concerns that people have. That's really my contribution.
Thank you so much, Nolutando. I got cut off a bit there, and thank you for those responses, and to Nick. I saw, Hassan, you have been interacting. There's a lot of interaction in both the chats and the question and answers. So maybe I'll hand over to you to make some comments about some of the questions you have responded to, and any other comments. And then I will come to Morena. Over to you, Hassan.
Yeah, thanks so much, Charles. I just want to engage with the audience really about adverse events. There are lots of questions about the side effects of the vaccines and how harmful they are, and why should people get vaccinated? If these vaccines have all these side effects. So I think, as Nolutando has very nicely said, I mean, these side effects are rare. They're being monitored. So, of course, there are common side effects like Dr. Crisp has very nicely said, you might feel a bit off color, you might have some pain and so on. There are more common sort of side effects that one get. And then there are more serious side effects, but those serious side effects are rare. But I think the important thing is when we talk about side effects, we have a choice. The choice is to risk getting COVID or to endure, a risk that may be associated with the vaccine. So COVID itself has much higher risks of being hospitalized and dying compared to any side effects that the vaccines may incur for you. And I think it's that balance. I think when we talk about safety, when we say safe, we can't talk about safety in absolute terms. Most of the things that we do on a daily basis, be it drive a car or go for a walk or even take a taxi, all of those have risks attached to it. We don't think of it, but most of the choices, even the food we eat, for some people may be, if you're allergic to seafood or if you're allergic to nuts, you might have a severe allergic reaction. So risk is all around us. The question really is, what is the safer option? Is the safer option to get vaccinated or not vaccinated? What are the consequences of not being vaccinated? And that's really the balance that we need to have in mind. And all the agencies around the world, be it the World Health Organization, the European Medicine Agency, the CDC or FDA in the USA have argued, they've monitored these risks, they've enumerated them, they've spelled them out, as we should to the public as well. But they've said very clearly the benefits of the vaccine far outweigh the risks. And what they mean is rather be vaccinated than suffer the consequence of developing COVID. And unfortunately, many of us, again, there are personal stories of family members, friends, people that we know who've either been hospitalized or died. And that's a great tragedy. But vaccinations do provide us with the opportunity to reduce the risk of that happening and to make us all feel safer again. The last thing I want to say about safety is that we want adverse events to be reported, but one must clearly differentiate between the reporting system and the assessment of causality. So we have situations where a day or two or a week after a vaccination, someone has died. So that's been happening here and around the world. So that gets reported and documented, and that's the reporting system. But what follows on from that is an assessment as to whether that event is related to the vaccine. And again, it's something that I've been involved in and I've monitored from around the world, is that more often than not, there are other reasons why someone has died. People don't suddenly stop dying. We know that in the old age homes in the Western Cape, there are 35 deaths a week. So you expect a certain number of deaths to occur. And just because it happens to happen after a vaccination doesn't mean it was caused by that. But nevertheless, we have an obligation to investigate that. And that's what the reporting system is about. We encourage people to report. No one is restricted from reporting adverse events. It goes into our system, and we have good systems where we evaluate these adverse events, check whether they are related or not, and then respond accordingly. But so far, from all the monitoring that I've seen, the reports that I've seen, we have very safe vaccines, and that again, as I've said at the beginning, the benefits of these vaccines far outweigh any risks, and it's something that we should feel confident about going forward. Thanks so much.
Thank you so much, Hassan. And I see there's been a lot of engagement, and the images there showing how people really identify with what you just said. There have also been questions around manufacturing, around mRNA vaccines. And so maybe, Morena, with those questions that have been asked, and then other points you might want to raise around vaccine manufacturing and what the plans are for South Africa. Over to you, Morena.
Thanks, Charles. I was trying to look for the relevant questions, but I think I've been quite fascinated, obviously, with the implementation issues. So if we can find the mRNA one, but at the moment, maybe I can just explain the context of mRNA and what it has done to the vaccine community, particularly for many of us, even, I mean, that have been in the vaccine manufacturing game for a while, in terms of how a game changer it was. So before December 2020 came, I think many in the traditional vaccine community were not sure about this mRNA technology. So we knew of the concept, we knew of how it would work. You would send, it's not necessarily the whole protein that gets developed. It's a messenger. It's like sending a letter and dropping off somewhere so that a factory can sort of like take place. So it's not building the factory necessarily and transporting it, but it's really sending a letter that has an instruction so that the factory gets built. This factory, of what we term antibodies. I think it's been a very welcome development from a technological perspective. I mean, from our side, the fact that we're the first to do one with Pfizer, even though it's a fill finish, and we'll be learning a lot from this, I think, talks also about the capability that Africa and South Africa has. There's been many skeptics, and less so in South Africa, but elsewhere, about what Africa can actually do. And I think us and others have shown that actually there is, we can do more. mRNA in itself, I think we're already, exploring other uses of it beyond COVID. And so I think it's a very exciting space that I think will have other applicabilities. Even those that are now having mRNA were actually not designed it against infectious diseases. Most of them were doing it against the likes of oncology. BioNTech had a flu program that they were doing it, and they had an early TB program that they were dealing with the Gates Foundation. But a lot of their portfolio was in oncology, much like Moderna. But I think you're going to see a lot more coming through in terms of infectious diseases, because we now have a proof of concept, in COVID, and a proof of concept that works well. I mean, the vast majority of the US has been vaccinated by mRNA, both being Pfizer and Moderna, and Israel has essentially been a Pfizer country. And you can see the stats having come down. So despite the question marks about boosters and all of this, but I think it's a welcome technology that even when we want to look upstream in terms of product development, which is something that we're still passionate about, we want to deepen our experience as a company in terms of the know-how of mRNA. So we will be investing people and wherever we can in terms of mRNA technology. So I'm not sure what the specific question was around that, Charles, if I've missed it. But yeah, that's just my 2 cents around mRNA.
Okay. Thank you, Morena. We might come to that in your closing remarks, where I will look for that. But there has been a lot of engagement and a lot of implementation issues, and understandably, because we are currently rolling out in the vaccine rollout phase. So we started a bit late, and we like the engagement, and we are probably getting close to when we will end, but maybe another 10 to 15 minutes for the session. And I would just like to just go around again, starting with Nolutando, then go to Hassan and Nick, and then you, Morena, to just give final remarks. And I think the audience has been enjoyed this, and there's a lot of information that has been shared and exchanges in the chat and the question and answer session. So over to Nolutando for your last comments.
Thank you so much, Prof. I think there have been some very interesting comments on the chat, and I think most of what people are referring to in terms of which communities and which influencers within the communities could be targeted to champion vaccinations and to try and counter the messaging around, vaccinations, and, so that we can deal with vaccine hesitancy head on. I think all those comments are, are considered, and I mean, they are already in the campaign plan that we are working on. And I think there's another, big aspect around, incentives. How we structure incentives. I think other countries have, structured various incentives to drive vaccination uptake. So it is also important to understand in our, South African context what works best for which populations, and the structure of those incentives. Obviously, it must be something that we don't consider to be, against good health care. So we must be thinking about incentives that we think will work. And it's really just applying behavioral economic principles in understanding what drives people. But I think for me, you structure those incentives, but structure them, parallel to a very robust communication plan around, addressing people's concerns around clinical safety and efficacy of vaccines. So I think it's really just focusing on what works, taking learnings from various other countries, but adapting those to the South African context so that we can really drive up uptake. Because I think vaccinations, as we all know, are our only hope in getting the handle over the pandemic as it is.
Thank you so much, Nolutando. And I acknowledge there's so many participants with the questions and also the comments that are coming there. Zain Mayed, Adel Baleta, Leraton Kosi, Rose Bonnet, and the others. Thank you so much for the interaction. Hassan?
Yeah, thanks so much, Charles, and thanks for chairing this session. And thanks to the audience for all the very useful and very interesting questions. I think the last thing I just want to say is that, whenever we open up an age group, there's a rush for vaccination. But then there seems to be a slowdown, but it's not a slowdown to zero. There's a steady stream of people who are middle adopters and late adopters. And I think it speaks to something that Nolutando said. I think we need to be patient. We started with a sprint, but we're now in a marathon. And it's going to take time for us to, build the trust, educate the public, and educate our health workers as well. I think there's been lots of useful comment about, well, what about health workers? The majority of health workers support the program, but there are exceptions to that rule. They need to be advocates for the vaccination program as well. But we also need, community engagement, building trust. And that's a big word that's come up in many of our discussions around vaccine hesitancy. Who do people trust? And how do we get people to trust the vaccination program, to trust the health system? That's not an overnight process. It requires a slog. It will take time, but we need to invest in that time. And I think we will continue to see a steady stream of people coming forward for vaccination. We also need to make the vaccination process easier. As Dr. Crisper said, we are constantly learning about how to make vaccine sites easier to access, how to take vaccinations to the people instead of them having to come to us. And then, of course, addressing people's concerns. And I think this is something Nolutando mentioned as well. We do need to listen to people without judgment, take them along with us on this journey, rather than seeing them as the enemies of this program. So on that note, thanks so much, Charles, for the opportunity, and thanks to the organizers for the opportunity to be part of this program. Thank you.
Thank you so much, Hassan, and thank you for making the time. So, Nick?
Yeah, thanks very much. And also, thanks for the opportunity to share some ideas, and to the other panelists for participating and creating a great platform. So I personally think that this is not about government, and that if the public believe, and we lead them to believe, they need government to vaccinate them, we have a serious problem on our hands. We're not vaccinating because government wants us to vaccinate. We are vaccinating because we know it's the way to protect us as a society and have a life. And we as health professionals need to make sure that that's the message we get across. I happen to work in government. I happen to have worked in government now for 3 months. Prior to that, I was very happily retired, looking after my future. And I came back because this is the right thing to do at this point junction in our lives. We need to take control. And we need to give people sufficient information, sufficient leadership, sufficient colleagues, people they look up to, family members, church leaders, traditional leaders, politicians at a local level, youth leaders. Every single one of these people who has influence over other people, parents, children who look after their elderly folk, every single one of these people needs to understand that it's got nothing to do with the government. Nothing. Our job in government is purely to make sure we buy and distribute the vaccines. And as I said, now we need to do better to get ourselves organized, to get the vaccines to more sites, more accessible, and do a better job of what we do. We know that, and we will do that. But this vaccination campaign is about protecting us, our livelihoods, our families, our friends, and having a future for our children. It's got nothing to do with the government. Thanks very much.
Thank you so much, Nick, and thank you for making the time to have the DDG with us for this time. Israeli, we appreciate that very much, and the engagement that you have with the audience. And Morena, the question that was about mRNA was about the tech partner for the WHO Hope for mRNA vaccine manufacturing. Maybe you can talk to that, and also about what the agreements have been and what the plans are for the transfer of that technology.
Okay, yes, thank you very much for the chance. And I think a very important question that I can just contextualize. So we have an agreement that I think everybody knows of with Pfizer, on doing some full finish of their mRNA vaccine, not only for South Africa, but for the continent, which is very important because as South Africa gets its act together, which it is doing now, the rest of the continent mustn't be left behind. So I think the fact that we can export the likes that Aspen can export, I think is a very good initiative. The mRNA hub that the World Health Organization has announced, for which BioVac is one of the consortium members, is a separate initiative. And that's a very important one because it's talking about what I described earlier in terms of going upstream, where technology should be identified for those that want to work with the hub, that can share the technology with the hub. If nobody wants to share, and WHO is driving those discussions, if there are no volunteers for sharing the technology, there is a plan B where some technology actually exists. As an example, the University of Cape Town and WITS have some capability, and there's already training that's happening, which means that we can actually start developing something from scratch. Like anything, it will take longer, but it's fine. The important thing is for us not to just be limited with a downstream part of manufacture, but to be able to really go upstream and develop capability. And I think part of my parting shots, Charles, I think to the community that's out there is that assuming we value the need for local vaccine manufacture as demonstrated by the scarcity of COVID vaccines and the exports and all of that, I would advocate that we continuously support Africa being a vaccine manufacturer. And if you're a vaccine manufacturer, you become a manufacturer of biologicals. And, it goes on and on and on. And for a number of reasons. So the risk in terms of supply, I think, has been demonstrated. I don't need to go too far down that road. I think the important thing that we need to recognize is that we often, and we're a very Western biased society where we read about Europe and the US, and people will hear about the Silicon Valley, the biotech world that's happening there. We'll hear about the Boston area in Massachusetts and we'll hear about Leiden in Netherlands, and Ireland doing this and all of this. And I'm sure people know that better than what they know about what's happening in South Africa. And I think in order for our children to be able to even get, because it's a growing industry, it's complex, but it's modern, and if our local industries can be supported, not only can we be able to supply the right products, but we can create meaningful employment. We have many scientists that want to come and work for us, many of which we don't even have capacity because we are fairly small. But you can imagine, and others, we know that we've lost others to overseas companies in other countries, and where people want to have that skills base from a science perspective and all of that. So it's not only about the end product, but it's also about creating an ecosystem so that we do become, the Massachusetts of the world. We become the Silicon Valley of the, and we do have the capability. And so I think we need to look at it much more holistically. But with that, we need, so we need to be kept on our toes. So let's be, as an industry. So I think that's first and foremost. We do need support from the likes of government. No big industry has, from the developing world. If you take India, you take China, you take Argentina, which is a very interesting case study, and you take Brazil, and you take Indonesia. All of those large industries were there because government gave some support, whilst keeping private industry on their toes. And that's a fine balance that needs to be there. It needs to be you need to have longevity, but we also need the public to be able to support us in doing that, and NGOs. But it's a long road. It's certainly not a sprint. That much I must say. And I'd like us to not forget, post-pandemic, the pandemic will end. That much we know. We just don't know when. But I'd like us in 2023, 2027, 2034, that we continuously talk about, the sustenance of vaccine manufacture, because it will deal with pandemics, but it will also deal with, the fundamentals of the EPI program. BCG was out of stock. BCG is one of the oldest vaccines out there. It was out of stock in 2015. We've had some measles vaccine disruption. Now, people have forgotten what measles looks like, but those are some of the things that we do, and we don't want to be reminded through risk of supply. And if we have a sustainable industry, that's how we can mitigate around that. And again, not only from South African perspective, but from an African perspective. But on that note, thank you very much for the invitation, Charles.
Thank you so much, Morena. And on behalf of the panelists and the organizers, I would like to thank the audience for being there through the whole session, for the chats, for the emojis, for the questions and answers, and some of the audience who've answered some of the questions, and for the interaction. And on behalf of the audience, I would like to thank you, the panelists, Hassan, Nick, Morena, Nulutando. Thank you so much for giving so much of your time and your wisdom. And also thank you to Gtac for giving us this opportunity. We also plan to have Professor Glenda Gray as part of the panelists, but she is busy with other duties. And I think the panelists, the members that were here, have done justice to this topic. And I thank you all so much. And please come back tomorrow for the rest of the winter school. Thank you so much, and have a nice day, the rest of your day. Bye-bye.
Thanks, Prof.
Bye. Thank you.
Bye-bye. Thank you.
Bye-bye.
Thank you, everyone.
Thank you. Bye-bye.